A warm welcome, everybody, to the Kiel Imaging Seminar. It is KIS Monday again, and we are grateful to have you all with us tonight. We have a fantastic speaker today, and it is my absolute pleasure to introduce to you Dr. Robert Edelman. Dr. Robert Edelman is a Director, Advanced Imaging Research and former Chair of Radiology at North Shore University Health System and Professor of Radiology at the Feinberg School of Medicine, Northwestern University. He is recognized for seminal research contributions in the field of magnetic resonance imaging and is the recipient of multiple grants from the National Institute of Health. His achievements include recruiting and leading an internationally recognized interdisciplinary research group that pioneered MR and angiography for imaging of the coronary arteries and dynamic contrast enhanced MRI in myocardial perfusion, applied perfusion, and diffusion MRI to the early diagnosis and characterization of stroke, and showed the feasibility of anatomic and functional MRI of the lungs. His current research focuses on the exploration of a novel class of steady-state MRI sequences called T1 Relaxation-Enhanced Steady-State, for short T1RESS. His research group recently demonstrated that T1RESS greatly improves the visibility of brain tumors in contrast-enhanced MRI and rivals MP-RAGE in that regard, which is considered a standard in clinical practice. Most recently, highly accelerated BT1RESS techniques have opened up the door to new clinical applications for cardiovascular MRI. Before we start, to the audience, please wait with your questions until the discussion. And with that being said, Dr. Edelman, the stage is all yours.
Oh, thank you very much. It's a great pleasure to present to this outstanding group of physicians and researchers. And I love the opportunity for collaborations across the Atlantic. And I hope this discussion will lead to some interest and we'll be able to work together and take this and other research activities to the next level. So today I'm going to present some of our recent work using this T1RESS or TRESS technique, which provides some interesting options for imaging, originally developed for brain imaging and then cardiovascular. So let's get going here. So what is TRESS? So this was originally published in the journal Science Advances back in 2020 as a brain tumor imaging technique. And basically, this is a new family of MRI pulse sequences that uses a three-dimensional steady-state free precession readout with a T1 weighted magnetization preparation. And what's interesting is that depending on which variation of the sequence you use, you can make the blood look either bright or dark. So the balanced version, which uses a true FISP readout, makes the contrast-enhanced blood appear bright, whereas the unbalanced version makes the blood appear dark. In other respects, the sequences are very similar, and yet the bright and blood contrast are dramatically different. And as I mentioned, although it was originally developed to improve the sensitivity for brain lesions, we think its greatest promise is in the cardiovascular system and lungs. So this is an example of a sequence that probably none of you or very few of you have ever seen. This is a PSIF sequence, a reversed FISP sequence. And the FISP sequence you've probably never seen either, because that dates back to when I first started working in MRI over 30 years ago. And this is the predecessor to the true FISP sequence that we use all the time, for instance, for cine imaging in the heart. But this is a more primitive version of that. Here we see the cerebrospinal fluid appear bright, and there's not much interesting out of this. But once we add a T1 weighted magnetization preparation, the background tissues become dark and we get some very nice anatomic delineation of the brain. And of course, the T1 weighting is essential if you're going to use a technique with a contrast agent, because of course, when we image with gadolinium-based contrast agents, we need T1 weighting to see the enhancement. This is the dark blood version of the TRESS sequence, what we call UTRESS for unbalanced TRESS. It uses an unbalanced readout. And what do I mean by that? So again, we're used to the true FISP sequence. If you're a Siemens user, we call it true FISP, or balanced steady state free precession. And true FISP is motion compensated along two directions, and it's balanced in all three directions so that we don't dephase the spins. With the FISP or PSIF sequence, though, we don't have the extra balancing aspect to make sure the spins are flow compensated. And this makes, as a result of this, the blood becomes dephased and it becomes dark. And in fact, dark blood contrast is advantageous for neuroimaging. We don't use it as much for cardiovascular, but I'll show you that there are some very interesting potential applications for this dark blood contrast there as well. So here's an example of a typical MP-RAGE sequence, a 3D gradient echo sequence that's used at least at our institution all the time for imaging of brain tumors and other lesions. This is the FISP version of UTRESS, which basically is gray blood. And if you look at the venous sinus here, you can see the blood is suppressed compared to the MP-RAGE, but it's not completely dark. The other thing you'll notice is that the lesions, the enhancing metastases here, are much better shown than with the MP-RAGE. And in fact, the benefit of this technique in the brain has been much higher contrast and also the vascular suppression. If you then do the reversed FISP or PSIF readout, instead, you get a similar delineation of the metastatic lesions, but now the flowing blood appears black. So we have the ability to modulate the blood signal based on what kind of readout we use, FISP or PSIF. And if we want the blood to appear bright, we use a true FISP readout instead. So here's an example where we compare MP-RAGE to the PSIF version of the TRESS sequence for a patient with a small meningioma. Now, in this case, this meningioma is right next to the venous sinus. It's really kind of difficult to say what is tumor and what is the enhancing blood vessel. But when you use these blood suppressed sequences, the UTRESS versions, we see that the lesion is seen very nicely, but now the blood appears dark. And so you get nice distinction between the flowing blood and the enhancing lesion. Now, if you use a true FISP readout, you get some really spectacular images of bright blood. So this is an example of this. These are the source images, and this is the three-dimensional reconstruction. And this is T1 weighted. So this is not a non-contrast scan. This is a contrast-enhanced scan. And you just get a tremendous amount of background suppression with this technique, and yet the blood appears bright. So we'll come back to this because although we don't use this bright blood techniques all that much in the brain, we do use it quite routinely for cardiovascular imaging. All right, let's move on to the cardiovascular applications. Where did the idea for doing this come from? Well, one of the challenges I've had, more on the MR angiography side than the CT angiography side, but really on both, is that you have to do contrast-enhanced MR angiography and CT angiography during the first pass of contrast agent if you really want to see the blood vessels optimally. That's because you need the highest concentration of contrast agent in the blood, and that's only during the first pass. And after the first pass, the agent becomes much more diluted. As a result of this, whether you're doing a contrast-enhanced MR angiogram or a CT angiogram, the useful post-contrast time window is really just a few tens of seconds. It's a very short time window. If something goes wrong, you don't get a second chance. So, we have some technologists that are very experienced with MR angiography and others that are less experienced. And then we may have issues with the technical aspects for the less experienced technologist. We may have some patients who cough during the exam or move during the exam, and then you have a problem because you've administered the contrast agent. What do you do? You're kind of stuck. And then for venous imaging, you can't image during the first pass, obviously. So you have to do delayed scanning when the contrast agent's more dilute. And this typically requires administration of twofold or threefold concentrations of contrast agent. And it's even then, the image quality may not be optimal. So in the United States, we have the option for ferumoxytol-enhanced, contrast-enhanced MRA. So ferumoxytol, it's an iron-containing blood pool contrast agent. It has a half-life on the order of about 17 hours. So it's ideal for equilibrium phase angiography. In other words, angiography well after the first pass. It is safe for patients with impaired renal function. And in fact, the contrast agent, this pharmaceutical agent was developed as an iron replacement therapy in patients with bad renal function. However, it has several drawbacks. In the United States, it's much more costly than gadolinium agents. It has a warning from our Food and Drug Administration. You have to administer it over 15 minutes while a nurse is supervising. So it's from a workflow perspective, it's very inconvenient. And my understanding is it's not currently available in Europe. So these are all drawbacks. And then as someone who does cardiovascular imaging routinely, another drawback is that you can't use it to image late gadolinium enhancement or for first pass myocardial perfusion imaging, which we routinely do in adult patients. On the right, you just see an example of this very nice angiogram done with steady state imaging using ferumoxytol. So it is a very good contrast agent. It's used routinely in pediatric patients in the United States. So let me propose a new way of doing things. And that is, could we mimic the effect of ferumoxytol, which allows you to image for many, many minutes or even hours, actually, after giving the contrast agent, but using a standard gadolinium agent that we use routinely? So this is where we come into something called equilibrium phase TRESS. So this is taking our neuroimaging technique, the bright blood version of this, and saying, okay, we're now going to take this and use it in the cardiovascular system. So it's been very interesting to sort of take a technique that was developed in one system and then apply it in another and kind of go back and forth and use advances developed in one organ system to benefit the other. So it's been a fun project to work on. So this is a pulse sequence diagram for the TRESS sequence. And it's really very simple because at the end of the day, this is just a 3D true FISP sequence with some minor modifications. We do some good fat suppression and some other things to reduce artifacts. And then we have a T1 preparation. In addition, this uses a very high sampling bandwidth to minimize artifacts and to keep the echo time short. The next thing we do is we use very aggressive two-dimensional parallel and partial Fourier scan acceleration, which allows us to either do a breath hold acquisition or a very fast navigator-gated free breathing scan. We get high temporal resolution, which freezes cardiac motion. And what's unique about this is that the vascular enhancement depends more on the T2-T1 ratio than just the T1, whereas with standard twist or gated contrast-enhanced MRA, the vascular enhancement really depends only on the T1. So what is the difference between doing TRESS versus just doing 3D true FISP? Because probably some of you have used 3D true FISP, like a navigator-gated version for imaging of blood vessels. Even without contrast, you can do that. And this is an example. This is a case we did where the patient happened to have both pleural and pericardial effusions. And one of the challenges is if you use a 3D true FISP sequence, then any fluid will appear bright. Edema will appear bright. So the contrast isn't really ideal for getting anatomic images. It works well in people who have completely normal anatomy, but when you have something like this, how do you differentiate this, for instance, as pleural effusion from the blood? It's a little bit tricky. But once you apply a T1 weighted preparation, all those artifacts go away, all the fluid signals go away, and you get very nice anatomic delineation, and we can see the aortic arch and other vessels. All right, so here's an example, one of our earliest cases, where we were able to show the utility of this equilibrium phase technique. So this is a patient where we did a nice twist study, worked fine. This was a gated contrast-enhanced MRA, which was okay. I don't love these scans. They're okay. I think they could be better. But if you wait 15 minutes or even a few minutes, the image quality becomes non-diagnostic. And that's typical. That's why we image during the first pass. But if you use this TRESS technique, we see that the image quality actually is just as good as it was right after contrast infusion. So this is interesting, isn't it? So this is equilibrium phase imaging with diagnostic image quality. So why does this work? And the reason is that if you look at the T2-T1 ratio of the blood pool, pre-contrast, it's pretty low because the blood has a very long T1 relative to the T2. But after contrast, the T2-T1 ratio goes way up, goes up actually by about a factor of 7 or 8, and stays up for tens of minutes. So how does this help us? Well, the TRESS signal is dependent on the T2-T1 ratio. So what we find is that compared with pre-contrast, the intravascular signal is almost doubled and stays that way for tens of minutes. And that does not occur with standard contrast-enhanced MRA techniques. And then we just published a paper in JCMR, Journal of Cardiovascular Magnetic Resonance, and we did a study where we looked at the actual blood pool signal as a function of time. And if you look at imaging, let's say 5 minutes post-contrast versus 25 minutes post-contrast, what you find is the signal is almost the same. The signal here is about 80 to 90% of the signal here, which is really not even visible to the naked eye. So even 30 minutes post-contrast, you get diagnostic scans. So here's an example, a nice twist study of the aorta. And this is breath hold equilibrium phase TRESS, obtained 5 minutes post-contrast. So these are really quite spectacularly nice images. We can image in multiple planes. So unlike a first pass study where you have to pick a plane, so when we do twist or gated MRA, we have to say, oh, we're going to do a candy cane or we're going to do a coronal. You can do a candy cane, you can do a coronal, you can do an axial. There's no time limit on these scans. And then, for instance, you can do something like this, where you want to do whole body MR angiography. You can do that because you can just do overlapping acquisitions, and the software and the scanner actually can merge them automatically. And you can see this very nice study going all the way from the neck down to the pelvic region. And that's because, again, there's no time limit. We can image this. Each scan is a breath hold here, and we can do multiple breath holds as many times as we want and put them together without losing signal. Then if you have a technical issue, this is one of the things I like most about it. Here, for instance, the technologist was doing a gated MRA, and for some reason the timing was off, and I don't know why that happened, but we didn't get a good view of the ascending aorta. So we just run the TRESS afterwards, and you can do that immediately afterwards. You can wait 5 minutes, you can wait 20 minutes. It works just as well. Then for slow flow, this is one of the interesting applications for imaging of slow flow or veins. This technique is really ideal because there is no time limit. So here's an example. We do a twist study of a patient with a type B aortic dissection. And you can see the true lumen here and the false lumen, which fills in a more delayed fashion. And unfortunately, because there's such slow flow, we really don't completely opacify this on the gated contrast-enhanced MRA. But on the TRESS, which we obtained 5 minutes later, you can see both lumens very well, and as a result, we can see the dissection flap perfectly. Here's another example of type B aortic dissection in someone where the false lumen is occluded. And here we see the true lumen. Here we see the occluded false lumen. And with this technique, we feel pretty confident, although really we haven't done a full validation study. This is something, if someone's interested, you could do it. Because of the nature of the technique, thrombus is going to appear dark because it's a T1 weighted technique. The thrombus appears dark and the patent vessel appears bright. So we feel pretty confident that we can reliably distinguish slow flow from thrombus. So here's an example of a patient underwent a coronary CT angiogram, and as is not that uncommon, we saw some lack of enhancement of left atrial appendage. And the problem with these coronary CT angiograms is we don't typically do multi-phase. If we're doing a pulmonary vein study, we always do an additional delayed phase, and we can pretty reliably distinguish thrombus from slow flow in the left atrial appendage, but not for CT angiogram. So this patient came back and we did the equilibrium phase B-TRESS, and in fact, it shows perfectly that there's no thrombus. And we can wait as long as we need to in order to make sure that these areas fully enhance. Another potential application is for congenital heart disease. And here's an example of a patient who has a little bit unusual anomalous left pulmonary vein to the left brachiocephalic vein. They're more commonly on the right, but they happen on the left too. And you can see that with the CT, but it's not ideal. Yeah, I mean, it's present, but it's not ideal. The time resolved, the twist conscious enhanced MRA really doesn't opacify this vessel adequately. But on the equilibrium phase B-TRESS, you can see it quite perfectly, including the junction with the left brachiocephalic vein. Here's another example. This patient had several anomalies: partial anomalous pulmonary venous return, a left superior vena cava, and a sinus venosus defect, which are all well shown on the CT. But what's interesting is if you look at the left superior vena cava, it really doesn't opacify well because the injection in this case, I guess, was on the right side. And the other thing is that the field of view of the CT in terms of the scanning didn't include the top area because again, this case was actually done for coronaries. They didn't know until after the CT was done that the patient had a congenital heart disease. But with the MR, we can get a full field of view. We can allow enough time for this anomalous left superior vena cava to fully opacify. We can see the anomalous connection of the right pulmonary venous return. And we can even see at some level here, right here, we can see the sinus venosus defect. So this is pretty interesting. There is another very good technique we've started using that comes from Renee Butner's group, which is this INAV technique, which I think is really excellent so far in showing the heart, and is another approach for this. But so we've just done a few cases with congenital heart disease, and the results look promising. This is a patient who was undergoing chemotherapy, relatively young patient, unfortunately, and developed thrombus at the tip of the portacath catheter in the right atrium. And you can see that nicely in the cine. But this is now a breath hold 3D B-TRESS study. And you can do one breath hold here and then do multiplanar reconstructions, as you see here. So you can, in fact, even see the catheter, which is not visible with the regular sequence. Now, this next case was really interesting. This is a patient who came in for a completely routine outpatient cardiac MRI. Nothing particularly relevant in the history other than a few weeks ago she had gone on a overseas trip and had some leg surgery, minor leg surgery after that. But she was here because she was having some shortness of breath. And none of the regular sequences that we did for the heart really showed much of anything. But then I decided to run the B-TRESS. just for research purposes, and sure enough has this huge pulmonary embolism, actually had several pulmonary emboli. So we had to bring the patient right to the emergency department and confirmed on a CT scan this patient had, in fact, bilateral pulmonary emboli. So there's a pretty good chance that the patient would have gone home, and I might either have entirely missed the diagnosis or only noticed it in reviewing the scans more carefully later on. But this was good that she came in because this is a potentially life-threatening abnormality. And she, in fact, also had some rightward, some D-shaped interventricular septum indicating increased pulmonary pressure. Here's another case, another cancer. In this case, a cancer patient had a lot of mediastinal adenopathy, and there was some question on the CT whether the SVC was occluded. So we wound up doing the TRESS, and because the veins are so nicely seen, you can follow, this is just a breath hold TRESS. You can see that the SVC is in fact patent, even though it's encased by this large tumor. And we can do the multiplannar reconstructions and follow this all the way down as it goes into the right atrium. So I think for venous applications, this has potential utility. Any situation where you need to see late enhancement of the vessels to make sure that they're patent. Now, another thing that's kind of interesting, I don't know that it's useful or not, but we scan a fair number of patients who, as I'm sure you do, mostly CT, of course, prior to TAVR procedures, and we get these patients with severe aortic stenosis. But sometimes we can identify it actually on the MR, and the TRESS sequence, for reasons I'm not sure I fully understand, but it seems very sensitive to valve calcium. And so here we see actually really nicely shown in cross-section when we do the multiplanar reconstructions, very similar appearance to the calcification seen on CT. And this is an example of a patient who has some dense mitral annular calcification. And I think you could see that on the cine imaging, but it's kind of hard to judge exactly what the configuration of that calcification is. So we did a TRESS study, and this is a minimum intensity projection, and you can actually see quite precisely the mitral annular calcification like you do here. So again, I don't know if this will be useful, but it's an interesting observation, and no one's published on this certainly. So it might be an interesting project to pursue. And certainly, I've now had a handful of cases where the first indication for valve calcification was on the MR because the patient did not have a prior CT. All right, let's talk about some further advancements with this technique. We now, we do breath hold imaging, but we also routinely now do whole chest TRESS with free breathing. And the nice thing about this sequence, first of all, it's whole chest, so you get everything. It's very short echo time, so you really have no issues with off-resonance effects. I haven't tried it at 3 Tesla yet, but I hope to. I'm hoping it will work well, even at 3 Tesla. You can see how nice the image quality is. You can take these images, then do multiplanar reconstructions. And what's a big advantage is because of the high acceleration factors, the scan time is actually less than 2 minutes in 90% of our patients. So it's very fast. In fact, a lot of our patients, the scan time is less than 1 minute. So it becomes very easy to run this. What I tend to do is we have about a 5-minute waiting period between when we administer the contrast and do resting perfusion, and we wait 5 minutes before we start doing the delayed enhancement. So in that time period, we can easily run this free breathing whole chest scan. And here you can see the image quality is quite nice. You almost always see the coronary artery origins, and sometimes even more, as you see here. You can see all the vessels very nicely. So it's just a nice way, for instance, instead of guessing at the vessel diameters like I normally do from the standard cardiac protocols that we do, assuming we don't have an angiographic scan because we do perfusion more often, we just throw this in and now I can get precise vessel measurements. This is a comparison of CTA in a patient with an aortic aneurysm, the ECG-gated standard technique, and then this is the TRESS, which I think works better. Now, another benefit is relating to incidental extracardiac lesions. Now, I am a radiologist, and my cardiology colleagues who are all outstanding, they really don't have a good way of looking at extracardiac lesions. They don't have a lot of experience in it, but also for those of you who do cardiac MR, the scout scans that we do that show outside the heart, they're very poor quality. We typically either use a low resolution two-dimensional true FISP or a HASTE sequence, and they're almost useless for extracardiac lesions. Now you might say, well, who cares? Well, when we read CTs, when we do a CT angiogram of the coronaries or any other structure, we always look at the other structures. We always look at the mediastinum and the liver and so forth. And the reason for that is that it's pretty common to have significant extracardiac findings when you do these studies that can change patient management. I've seen quite a few lung cancers, for instance, incidentally on CT scans. But the standard scout sequences are very poor for looking at these things, whereas our experience suggests that the whole chest TRESS is rather promising for showing these lesions. Here's an example of a patient with a metastasis on CT and on the TRESS. Again, this is a T1 weighted sequence, so it works very nicely for showing the liver lesions. And in fact, my next project is to start using this for abdominal imaging because I think the images are much better than we get from our standard VIBE sequences, for instance. And here's a patient with presumably hemangioma. Actually, several lesions are present in this case. We've also adapted this sequence for imaging of late gadolinium enhancement. And here's an example of a standard 2D late gadolinium enhancement in a patient with a hypertrophic cardiomyopathy. You can see the typical mid-myocardial enhancement. And this is a breath hold 3D sequence with substantially higher spatial resolution, again, based off the TRESS. And you can see very nicely the enhancement. And then most recently, we've created a dark blood sequence with this technique. And here's an example of the standard breath hold and motion compensated LGE that's standard on the Siemens scanners. And you can see this, what we think is a myocarditis at the LV apex. And this is the breath hold 3D TRESS scan adapted for a late gadolinium enhancement and with gray blood contrast, and you can see very nicely these lesions. And in fact, you can do multiplanar reconstructions, although we're going to push the resolution much higher. But you really see this very nicely. And we haven't been that thrilled with the standard two-dimensional gray blood and dark blood sequences, but I think this might actually be quite useful. So that's very early in its development. We're working on improving the temporal resolution. So for instance, we've got the temporal resolution down to almost 100 milliseconds here. In fact, we've got it down to 60 milliseconds in some of the most recent versions. And then you can, for instance, do both systolic and diastolic imaging to look at cardiac function. And then there may be extracardiac applications. So for instance, here's a patient who had an aortic graft and the aneurysm sac was enlarging. This is a CT from outside. They only provided us with the first pass study, and of course, they should have done delayed imaging. But on the equilibrium phase TRESS, you can very nicely see this endoleak. Here's the lumen of the graft, and this is the endoleak showing up very nicely in red. You can use this for looking at peripheral vessels. Of course, you're getting both arteries and veins here. We think there are ways of separating them out with some sequence modifications, but this is just the initial results with this. And even though this patient had a right hip replacement and partial knee replacements, we really don't see much in the way of off-resonance effects. And this is just a case of a patient with a large arteriovenous malformation. All right, let's move on to the dark blood approaches. So if we take the TRESS that I showed you in the brain and use it in the chest, we can get some very pretty images. I think it's actually good for the abdomen too, but I won't really talk about that. Here's a patient who we just did the other day. CT shows a colon cancer metastasis. This is the pre-contrast TRESS, and this is the post-contrast TRESS, and it's really quite a nice sequence for looking at liver lesions. But notice that the blood, unlike a standard vibe sequence, the blood is dark instead of bright. And in this case, we also did the navigator gated B-TRESS, and that also shows this tumor quite nicely. Here's an example of a patient where on the SCOUT scan, you might just walk past this thinking this is some sort of dilated vein. But if you run the UTRESS scan, the blood becomes dark and this mediastinal cyst is easily seen. I think for lung nodules, this is quite a nice technique. If you use VIBE, for instance, for lung nodules, you get a lot of signal from not only the nodule, but blood vessels. But if you use UTRESS, all the blood vessel signal goes away and you just see the lung nodule. So here's an example of a case. This was not my patient. I was actually homesick with COVID, but I got bored, so I was looking at interesting cases, and this patient was read out as asymmetric basal septal hypertrophy, which is correct. All this was correct. But then I was just sort of scanning through the SCOUT images and everything else, and I kind of wondered if there was something in the lungs. This was not reported. So when I recovered, I had the patient come back, and we ran UTRESS, and sure enough, we saw a spiculated lung lesion, and this patient came back and had a PET CT, showed stage 1 lung cancer, and which was successfully resected. So to conclude, this is an interesting new approach for imaging of the cardiovascular system. It's still relatively untested, but we've made a lot of progress already. There are both bright blood and dark blood versions that can be used for various purposes. When you use the bright blood version, it does extend the useful post-contrast scan window from tens of seconds to literally the entire study duration. So if we have a patient in the magnet, if I walk down and they're running the last late gadolinium enhancement scan and getting ready to take the patient off the table, I can run B-TRESS at that point and it works fine. We believe it reliably differentiates slow flow from thrombus, although that remains to be fully validated. We think it will have use in congenital heart disease. It might open up the ability to do very efficient whole body vascular screening. And we think it's better than standard sequences for incidental extracardiac lesions. You can do some nice volumetric imaging of the heart, and as we push the temporal resolution, we think we'll be able to do functional imaging. And then clearly, there's a need for further technical improvements and for a lot of clinical validation, which we hope we can work with you folks on. So thank you very much, and that's the end of my talk.
Very nice. Thank you.
Yeah, thank you. So I guess this is time for the question round. So for the audience, whoever has a question, you may go ahead. Perhaps in the meanwhile, I have a question. It's about TRESS. How does it compare to MP-RAGE in terms of scan time and resolution?
So in the brain. So TRESS is faster. So our standard TRESS for brain now, the Cartesian version, because we also have a radial Stacked-Storage version, which is a whole different issue, is about 2 minutes. And our MP-RAGE is about 4.5 minutes. And that's without doing any deep learning or fancy techniques. So standard is about 2 minutes. So it's about twice as fast as the MP-RAGE. And the spatial resolution is they're both 1 millimeter isotropic. Although in my experience, the MP-RAGE uses some filtering that makes the images look a little blurrier. So I'd say the TRESS is a little bit sharper than the MP-RAGE. And the Saccastars versions that we have a version that's about the same time as MP Rage, about 4.5 minutes, but the Saccastars version has the benefit that it has no motion sensitivity. So whereas an MP Rage will get very blurry and have ghost artifacts with motion, when you do Saccastars, there's no artifacts at all. So well, I shouldn't say that. There's some streak artifacts with motion, but they're usually pretty minor. So we actually collaborated with the group at New York University, which really pioneered the whole use of Saccastars, and they created this TRESS version for us. I haven't used it really in the cardiovascular system, but that's something for future work.
Sounds very interesting. Jan?
Yes, thank you. Fantastic talk. Very impressive images. Me as a physicist asking, so if I get it right, the basic principle is basically you add a stronger T1 weighting, right?
Yes.
To a sequence plus optional flow suppression or flow compensation.
So it's really a choice of whether you use a FISP readout.
Balanced or unbalanced, yes.
Is unbalanced, or a true FISP readout, which is balanced.
Yes.
Correct.
Which gives you either a flow suppression or flow compensation.
Pretty simple idea there. It's actually a pretty simple idea. Getting, tweaking the sequence to get good image quality with very high acceleration took a little bit of work, but it's actually the basic principle is very simple.
I mean, the simplest ideas are often the best, right?
Sometimes.
Often. Yeah. And you showed this T2 ratio graph. How would you, I think the T2 is as well usually shortened, right, by the agent. So I guess the T1 ratio would increase even further.
So that you bring up an excellent point, which is why I didn't think this was going to work originally, before I sort of thought about it some more and understood it. But so paramagnetic contrast agents, typically the T1 and T2 relaxivities are similar, right? So the T1 is shortened by the same percentage as the T2. So you might say, well, then it won't have any effect, right? But we're not dealing with
large concentrations.
Relativities, we're dealing with absolute T1 and T2 values. So what happens is, if you look at the T1 pre-contrast, it's about, for blood at 1.5 Tesla, I think, it's been a while since I looked at this, but I think it's 1,500 milliseconds, something in that range. I forget what it's, something on that order. And the T2 is 180 milliseconds for arterial blood. Post-contrast, the T1 in the equilibrium phase is probably 200 to 300 milliseconds. The T2 might go from 180 to 150. So when you do the T2-T1 ratio, it goes way up. So even though the T1 and T2 relaxivities are the same for the contrast agent, the actual T1 and T2 values change dramatically, and it's those values that determine the signal. So that's why it works.
Yes,
and that's why.
I was thinking that I guess with a pure T1 weighting, you would get even stronger contrast.
But the problem with doing pure T1 weighting, so there is T1 weighting in the sequence that you
doesn't really have that.
No. So this is kind of an interesting thing. You bring up a good point, because it's not true that the sequence, the contrast, is just T2-T1 ratio, because there's also a T1 preparation, right? So it's kind of an odd thing, and depending on the flip angle of the T1 preparation and also the time delay, you can modulate the T1 contrast. So you've got that basic T2-T1 contrast of the true FISP readout, and then you have the superimposed T1 weighting. So it's kind of a weird thing that I haven't fully, worked out all the details. But if you do a regular flash scan, there's only T1 weighting. And the problem with that is that the signal is going to be very low. The intravascular signal is going to be very low when you have a T1 of, let's say, 300 milliseconds. So the true FISP has much higher signal than a flash sequence. So
PSIF inherently has a high signal, and if you just add a strong T1 weighting,
so then you
yeah.
get the
yes, it's very
but
nice.
if you don't do the T1 weighting, you don't get the background suppression, right? So that's the problem with if you just do a 3D. In fact, I've been using the iNav technique, which is really excellent, but it doesn't have T1 weighting in it. So, it does create some issues if you're used to standard T1 weighted images. You get these true FISP images, and they don't have any true. They're not pure T2. They're kind of a weird contrast. So that's why I like the TRESS sequence clarifies that by making it T1 weighted, and it's very strongly T1 weighted, as we know from the brain. But you can adjust it, right? You can change it. You can add and change the amount of T1 weighting by varying the flip angle of that pulse and the TI. So that's why, for instance, I'm interested in using it for abdominal imaging because we're used to using Vibe. And we know in the brain that TRESS has much better contrast and much better lesion conspicuity after gadolinium enhancement versus Vibe or MP-RAGE. So I think this could work better, but that remains to be seen. But you have some good points. But if you try to do, I'm sure you've tried this. If you just run a 3D flash-based gated MRA, for instance, and you wait till after the first pass, the image quality is terrible, right? It's good. Whereas if you use a true FISP as the basis, it's much better. And also the signal noise is so much higher that allows us to do very high acceleration factors. Whereas if you try to match those acceleration factors with a flash sequence, you're going to run into problems because you won't have enough signal noise.
Yeah. I can ask on for the entire evening, but possibly there's others with questions too. Thank you.
Yeah, I think we have one more question from Professor Bolt.
Yeah, so thank you also from my side very much for this really fantastic talk. I was absolutely impressed by these images. In the past, we already had the opportunity to work together with the KIS MRR, together with Mona Saleh-Ravish, and this again, to me, it really seems to be a breakthrough with this contrast and this high resolution. During your talk, I was thinking about so many issues for a cooperation. You have been showing the images for the pulmonary artery with a fantastic detail resolution. I think this could really be a really effective clinical benefit for the patients, also in other entities, not only acute pulmonary artery embolism, but also in chronic thrombotic pulmonary hypertrophy and hypertension. What we also do is imaging of the vessel wall. And you have been showing this, the late gadolinium effect, which is really, really nice in the myocardium and all. Even in this topic, I would be very, very interested in a cooperation. But I was also thinking about late enhancement in the vessels. Vessel imaging is one of our hot topics in our department. In the brain, cranial vessel wall imaging and also body vessel imaging, as well in atherosclerotic disease, but also in vasculitis. So I would like to know if you have any experience in this field and if you would be interested to perform a cooperation with us, because we also very experienced clinical cooperation partners from cardiology for atherosclerotic disease, and also the field of vasculitis. We have experience, since 20 years, large vessel vasculitis, Takayasu arteritis, giant cell arteritis, and I really would love to do this TRESS imaging in the temporal arteries, but also in the aortic arch.
So that's very interesting. I have a little bit of experience. I think for intracranial, and I think the existing T1 space sequence has better signal to noise. So I'm not sure that the TRESS would be that useful, but we haven't pushed it much in that area. On the other hand, in the body, where I think it's not so easy to do T1 space in the body, that's where the U-TRESS could be useful, and I'd be happy to work with you on that. Of course, you don't necessarily need dark blood contrast to see the vessel wall. If you do high resolution bright blood, with the B-TRESS, maybe that'd be just all you need. And of course, we can do the navigator. We've pushed the spatial resolution quite a bit. We can do, for instance, 1.6 millimeter isotropic acquired in the body quite easily, and it's just a few minutes of scan time. So I'd love working with you on it, and probably requires some tweaking to get it to fit your needs. But I think that's definitely something that could be of interest.
Yeah, this would really be fantastic, because since several years, I'm searching for an ideal sequence for vessel wall imaging, delineating the outer part of the vessels, taking up contrast media in the late phase. We are using the variations of VIBE sequences, but we always had difficulties in ECG gating. Is this possible with the TRESS to do ECG gating?
It is ECG gated, yeah.
It is, no?
Yeah, normally it's ECG gated.
Yeah,
Yeah.
Perfect.
ECG, you can do navigator gating. The thing I didn't talk about in this talk, so if you do a stack of stars version of it, you can actually do perfusion imaging as well. So that's kind of interesting. So you can get actually dark blood perfusion images, which might be, for your purposes, kind of interesting, because then the vessels stay dark and the vessel wall will enhance. So we've done that in the brain, and it works quite well in the brain. I haven't really tried that in the body, but again, if you have an interest, let me know, and we can try to come up with something that might be useful for you.
Yeah, fantastic. I'm absolutely interested.
Good.
Are there questions? Last chance. That doesn't seem to be the case. So thank you everyone for being here. Thank you, Dr. Edelman, for this wonderful talk.
Thank you for inviting me.
Yeah. So I wish you all have a pleasant evening, morning, afternoon, depends on where you are. And until the next KIS imaging seminar.